Dear friends, I am going to present to you something completely unthinkable, something completely unimaginable, but extremely unfortunate. We don't have any financial interest with this video. A 29-year-old lady underwent implantation of implantable polymer lens for surgical correction of high myopia. A few months later, she developed some blurring of vision, which was progressive. She went to an ophthalmologist, for which, according to her, some laser was performed in both the eyes. Immediately after that, there was sudden, complete loss of vision in both the eyes. A week later, she reported to us in our outpatient department. Her visual acuity was hand motion close to face in both the eyes and was literally brought to us like a totally blind. On examination, she was found to have total cataract in both the eyes. The ICL was touching the anterior capsule. Ultrasonography was performed for posterior segment evaluation, and it was noted that there was presence of lens matter in the posterior vitreous cavity. Ultrasound biomicroscopy was then performed, in which a large posterior capsular tear was noted in both the eyes with lens matter protruding into the vitreous cavity. Then we correlated the history, correlated it with the clinical and investigative findings, and then we could figure out that the patient had undergone implantation of Phakic IOL for high myopia. Due to low vault and lens touch, she developed progressive diminution of vision due to cataract formation. She was wrongly diagnosed as having an intraocular lens implanted for cataract and associated with posterior capsular opacification, and for that a YAG laser capsulotomy was done, resulting in sudden development of total cataract and lens matter falling into the vitreous cavity. It was unfortunate, but it had happened, and the patient was bilaterally blind. A surgical plan was made. Since there was a large posterior capsular defect with intact anterior capsule and lens matter in vitreous cavity, a posterior approach for removal of cataract and fallen lens matter was taken with the help of a vitrector. 3-port pars plana approach using a 25-gauge vitrector was taken. The lens matter present in the lenticular plane was aspirated by the vitrector in the IA cut mode. The lens matter was completely aspirated using suction of the vitrector. This was followed by a pars plana vitrectomy and removal of the posteriorly dislocated lens matter. Since the lens matter was fluffy, it could be removed by the vitrector itself, and phacofragmentome was not required. The posterior surface of the anterior capsule of the lens was polished with a silicone tip, and the capsule was cleaned off the lens fibers completely that were attached to the surface as well as in the equatorial region. A 3.2 millimeter clear corneal temporal incision was made. 1% sodium hyaluronate was injected into the anterior chamber. The phakic IOL was gently brought above the iris, and one side of the foot plate was held with a forceps, and then it was pulled out of the corneal incision. A multi-piece, foldable, hydrophobic, acrylic intraocular lens was implanted over the intact anterior capsule in the ciliary sulcus. The corneal wound was closed with a single suture. Post-operatively, the uncorrected visual acuity was 20/30 on day 1, and the intraocular lens was well centered with a nice fundal glow. At 1 week, the uncorrected visual acuity was 20/25. The intraocular pressure on non-contact tonometry was 16, and on fundus evaluation, there was no treatable lesion. After 1 week, the other eye was operated similarly, and the uncorrected visual acuity at 1 week in that eye was 20/20 with intraocular pressure of 14 mm of mercury. An unfortunate and unthinkable scenario had happened, which no one can imagine. But it was managed well with optimal visual outcome and good patient satisfaction.